Hello guys, welcome to our channel. Today we'll be discussing the Sureshot last series part 3, and in this part 3 we'll be discussing more than 50 topics, and we can expect from the part 1, part 2, part 3 at least 50 to 80 concepts can be expected in the final examination guys. Please don't forget to watch the part 1, part 2 and the part 3. Okay, so please maximize this and also practice the cube math. So let's start the discussion guys. Sureshot series part 3. So first and foremost important one is the cranial fossa and cranial fossa contents. So first here you can see this is the Kirby form plate. So in the Kirby form plate we have the cranial nerve 1, olfactory nerve, and next the optic canal. So this is the optic canal, and in the optic canal you have the cranial nerve 2. Next is superior orbital fossa. Here this is the superior orbital fossa, and if you zoom in the superior orbital fossa, this is the cranium, right? And from the cranial fossa it will be coming into the orbit. And what are the contents of this one? Here the picture. So this is the superior orbital fossa. Okay, this is the superior orbital fossa, and the important nerves that is passing: lacrimal nerve, frontal nerve, trochlear nerve, and superior ophthalmic vein, inferior ophthalmic vein, and also other nerves in the medial compartment. This is the superior compartment, inferior compartment, medial compartment. But medial compartments have the separate ring. So this ring is known as a common tendinous ring. Okay, in the common tendinous ring, you have the superior branch of the oculomotor nerve, abducens nerve, nasociliary nerve, and also inferior branch of oculomotor nerve. And inside the tendinous ring, you also have the ophthalmic artery and the optic nerve. So this is how all the contents will be present in the superior orbital fissure, right? Next, moving on to the D. This is a D. In the D, this is known as a foramen rotundum. In this, you have the trigeminal second branch. Trigeminal second branch. Where is the trigeminal first branch? Trigeminal first branch is in the superior orbital fossa. Next, here you can see this is the ovale, and this is the trigeminal third branch. And here you can see this is the internal acoustic meatus. Acoustic means it is something about the auditory. So vestibulocochlear nerve and also the facial nerve which is passing here. Next, jugular foramen. Jugular foramen is the question that is asked guys. Jugular foramen here. This is the jugular foramen. The question was what are the three nerves that is passing here? So ninth, 10th and 11th. This is the one which will be passing here. Next, hypoglossal canal. This is the hypoglossal canal just nearby the foramen magnum, and here you will be having the 12th cranial nerve. And coming to the fifth, this is the eye, that is the foramen spinosum, and here you can see this is the meningeal branch of the fifth trigeminal third branch, and also middle meningeal artery is passing here. Next, carotid canal. Carotid canal is here. This is the carotid canal, and from there internal carotid artery is coming up, and foramen magnum is for the vertebral artery and the spinal vessels, right? These are the important contents of the cranial fossa and their important passing through whichever it is coming here. Next, moving on to the diaphragmatic opening. So in the diaphragm opening, we need most important is the vena cava opening, esophagus hiatus, and also the aortic hiatus, but they are in the different locations. Let's see. Vena cava at the location of the T8, esophagus at the level of T10, aortic is the T12. Next, what are the passing structures? In the vena cava only, inferior vena cava is passing, and right phrenic nerve is passing here. Next, in the esophagus, vagus nerve, esophageal branch of left gastric nerve is passing. In the aorta, thoracic duct, SGS vein is passing here. These are the contents that is passing in the diaphragmatic openings. Next, let's see lung helium. Lung helium is a potential question. This is the right side of the lung. This is the left side of the lung. Okay. So in the right side of the lung, we have the structures that is passing here. That helium contains of the epiarterial. This is known as a epiarterial bronchus. Okay. And just below the bronchus, you have the pulmonary artery, and followed by the pulmonary artery you have hypoarterial. Okay, just means below the arterial bronchi, and after that you have the pulmonary vein. Comparing to the left side is more occupied by the heart, right? And also we have only two lobes, so here there is no hip arterial. Directly it will be starts with the pulmonary artery and bronchi, and then the vein, pulmonary vein. This is how it is passing. And Above these structures, there is a arteries and the veins that is passing here. On the right side, you have the aorta. Okay, this is the aorta that is passing here. This is the aorta. And on the left side, you have the asgius vein. This is the asgius vein. Right? This is the potential question. Next, another picture, the nerve supply for the tongue. So first two thirds, the motor supply is supplied by the trigeminal third branch, and two thirds and one third is supplied by the glossopharyngeal nerve, and base is supplied by the vagus nerve. Next, coming to the taste sensation. Taste sensation, the two thirds will be supplied by the facial nerve. Okay, and in the facial nerve you have the specific nerve. What is the nerve that is a branch of the facial nerve? Chordae tympani. It is the chordae tympani. Remember, T for tympani, T for taste. Next, one thirds will be supplied by the glossopharyngeal nerve. Again the base will be supplied by the tongue, which will be the vagus nerve. And esophageal constrictions, here you can see esophagus have almost 40 centimeters to reach the stomach, but they are some specific constriction points. From the distance of the lower incisor teeth, if you take the considering the measurement at the location of the circopharyngeal junction will be 15 centimeters, arch of aorta will be 23 centimeters, crossed by the left bronchus at the 28 centimeters, and diaphragm is at the location of the 40 centimeters. Again and again, these two structures and their distance has been asked in the examination. Okay. Next, moving on to the another picture that you can see, this is the embryological development. This is the embryological development of the diaphragm. Okay, the important one is the pleuroperitoneal membrane. Okay, this is the pleuroperitoneal membrane. So, in the congenitally, if the patient is absent of the pleuroperitoneal membrane, so there is a high chance that they can develop the CDH, congenital diaphragmatic hernia, and in that the most common is the left side, which is common with the hernia name is known as a Bochdal's hernia. This is the Bochdal's hernia, and the B bag and mask ventilation is contraindicated in this patient. Okay, this is the important point about the congenital diaphragmatic hernia and their defect. Next, glomerular filtration. So you all know that in the glomerular filtration, the important points that you have to take note is the how these are working. See, let's see one by one. So the first one is the glomerular hydrostatic pressure. Okay, glomerular hydrostatic pressure. So how the glomerular hydrostatic pressure? This is the capsule, this is the arterioles, right? So glomerular hydrostatic pressure, this is the glomerular is going to give the pressure towards the capsule. Okay, this will be giving the pressure towards the capsule. So this is around 55 mmHg. This is the 55 mmHg. Next one. Next one, let's see. That is the blood colloid osmotic pressure. Again, this is the capsule, and this is the arteriole and the glomerulus, and the capsule is giving that structure. So this is giving by the Bowman space. Bowman space, the blood colloid osmotic pressure. This is around 30 mmHg. This is around 30 mmHg. Okay. Next, followed by another then that is the capsular hydrostatic pressure. Again, this is the capsule, this is the arterioles, right? And now the capsule is giving that pressure. Capsule is giving that hydrostatic pressure, and this will be around 15 mmHg. So how you are going to calculate this? So glomerular hydrostatic pressure means this one minus, this is the Bowman space pressure minus, sorry, plus this is the capsule, right? Capsule hydrolar pressure. Okay, and sum of this 55 minus 30 plus 15, so it will be comes around 10. Okay, 10 to 20 mmHg is the glomerular filtration that we are going to consider. Okay, and this is the normal of our body area. Next, coming to the filtration unit. So this filtration unit is very important. Okay, filtration unit is very important. Why the filtration unit is important, guys? Because we have to make sure that we are not going to waste our proteins, electrolytes, and any other important parts of our body during the secretion. So for that we maintain this filtration unit. What are the structures that is present in the filtration unit? First and foremost important one is the endothelium. This is the most important one. Okay, and this endothelium is fenestrated endothelium. Okay, this is the fenestrated endothelium. We can see this is how the fenestrated endothelium will be presented. Next, second one is the basement membrane. Okay, this is the basement membrane is highly in the negative pressure. This is in the negative pressure, and after that you have this podocytes. Okay, podocytes is the third one. So these three is going to comprise as a filtration unit for the proteins. Okay, this is comprises as a filtration unit of the proteins, and the basement membrane is consisting of the collagen 4. Okay, and also it will be consisting of the heparin sulfate. It will be also contains of the heparin sulfate. With these two, it is going to maintain the negative pressure, and also it will repel if there is any secretion during the filtration process. Okay, next let's move on to the ligaments. The gastrointestinal ligaments, the important points that you have to remember, what are the important ligaments? Let's see the one by one. So this is the liver. In the liver, between the right side and the left side of the lobes, if they wanted to connect, that will be connected by the falciparum ligament. Okay, that is for the connection of this both. Next, hepatogastric ligament. Hepatogastric ligament means this is between the liver and also from the stomach. This is the hepatogastric ligament. Next, hepatoduodenal ligament. Hepatoduodenal ligament have the importance. What is the importance for this ligament? It will contains of the portal triad. It will be contents of the portal triad. Here you can see this is the portal triad, that is a hepatoduodenal ligament, right? There will be presence of the portal vein, portal artery, and also the biliary structure will be also present here, that is known as a portal triad. Next, gastrosplenic ligament, that is between the stomach and the spleen. And next, splenorenal ligament, this is between the renal structure like kidney and the spleen. And the gastrocolic ligament between the colon and the stomach. Okay, these are the important ligaments and the identification. Okay, next, another picture that you can see, this is the classification of the liver segments. Okay, this is the classification of the liver segment, and the liver segment is classified from the portal vein. This is classified from the portal vein. Identification can be asked, guys. So first let's see, this is the second one, and here the third one, and 4a and the 4b, and from here it will be clockwise. It will be clockwise, 5 6 7 8. Okay, so come again. So one you cannot see, one will be in the posterior. On the anterior only you have to identify. So this is a 2 and 3 4 4b, and from here it will be the clockwise. Okay, and in the clockwise 5th 6th 7th 8. Okay, and the dividing one is the portal vein, and this classification is known as a coordinates classification. The scientist coordinate is divided this classification into these segments. Okay, next, gastric hormones. In the gastric hormones, the most important one is a gastrin. Gastrin will be important for the gastric acid secretion and also gastric mucosal growth, right? And CCK, cholecystokinin, important for the gallbladder contraction and also pancreatic enzyme secretion. Secretin is important for the pancreatic bicarbonate secretion and also suppression of the gastric acid secretion, right? Secretin main functions that you have to remember. Next, GIP. This is the gastric inhibitory peptide, right? So this is the insulin secretion is increased by this. Okay, that is why we use this for the patients, those who are suffering from the diabetes mellitus, right? GIP agonist we use, and also it will decrease the gastric acid secretion. Motilin is important for the motility like migratory motor complexes. Somatostatin is for the systemic inhibition, and it will decrease the pancreatic secretion, decrease the gastric secretion, decreases the biliary secretions. Ghrelin is for the appetite, and it having the minimal secretion. Ghrelin is having the minimal secretion. Okay, so these are the important points that you have to remember, and here I also given their cells. Okay, at least this function has to be remembered in the examination. Next, moving on to the chlorination. So in the chlorination, why the chlorination is important, guys? Chlorination is important for the water. Okay, so water supply, that has to be important for the chlorination, and in the chlorination we use these instruments. These instruments is known as a Horrocks apparatus. These are the Horex apparatus. What are the levels that we use? For the general drinking water, we use more than 0.5 ppm. Okay, for the drinking water. If there are any outbreaks, we increase this level 0.7 ppm. And for the pools, swimming pools, like there we increase 1 ppm because of more and more human contacts will be seen, right? So for that we will be increasing 1 ppm. Okay, and what is the most commonly used chloride? That is the hypochlorous ions and hypochlorite, but it does not cover hepatitis A, spore forming agents, and also helminth infections, polio, protozoa. All these are not killed in the chlorination process, right? This is done. Next, coming to this picture, what is this picture, guys? This is a bindi, and as per the new national health mission program, this bindi is consisting of the iodine. Okay, this bindi will be consisting of the iodine, especially for the rural women, to decrease the chances of the hypo or hypo hyperthyroidism, to decrease the hyperthyroidism. And also pregnancy people, they wanted to decrease the cretinism. That is why they use the iodine bindi by the national health program. Next, another picture that you can see here, this is the anemia mukt bharat. And anemia mukt bharat having the motivates of the 6 beneficiaries, 6 interventions, and 6 institutional mechanism. Okay, the 6 into 6 into 6 strategy was by anemia mukt bharat. And in that, the beneficiaries are children 6 months to 5 years. And here we are going to give the 20 mg of the iron, and 100 grams of the iron and the folic acid will be given for this patient bi-weekly in the form of syrup. And the children from the 5 years to 9 years, weekly once a tablet of the 45 mg iron and the 400 micrograms of the folic acid. And the adolescents between the 10 to 19, again this is also weekly once a tablet, 60 mg and the 500 micrograms of the folic acid. For the reproductive, pregnancy, and the lactating mother, same dosage, 60 mg of the iron, 500 micrograms of the folic acid is given. But the reproductive females, which will be given as a weekly red tablet, and the pregnancy woman daily at least 180 days, and also lactating mother also 180 days, that you should must give this drugs. Okay, that is the anemia mukt bharat that we are considered. Next, fluoride levels. Okay, so general fluoride levels are normally we use in the toothpaste is 0.7 and 1.2 ppm, because it can cause the skeletal abnormalities. If it is less than 5 ppm, it can cause the dental problems, and more than 1.5, it will be increasing to the dental fluorosis, and 3 ppm, more than 3 ppm, it can cause the early skeletal abnormalities. Okay, and if it is more than 5 to 10, more than 5 to 10, it will be causing the crippling. So some severe skeletal crippling will be seen in this patient. And for this fluoridation only, defluoridation, there is a technique that they used. This question is asked, Nalgonda technique. Okay, so Nalgonda technique is used for the defluoridation. Next, moving on to the another picture, that is a disaster. So in the disaster cycle, we already discussed that the disaster, for example, here the disaster is happening. Immediately after the disaster, there will be a response. We have to save the lives. So response is to save the lives and minimize the complications, minimize the immediate impact in the patients. And after that, the patients will be recovered. After that, the society will be recovered. After that, we are recovering the damage that is caused by the disaster. Okay, that is the recovery phase. This is all post disaster phase, and we have to prepare, right? To prevent that this much damage, we have to be prepared. So the pre-disaster, which will be prevent and minimize the future disaster, and also preparedness, which will be impacting like building damages in the tsunami areas and also earthquake areas, the building constructions, all this will be maintained like a preparedness before the crisis. Okay, this is a pre-disaster and that is a post-disaster. And the most common post disaster all the patients may encounter is the acute gastroenteritis. This is the common feature that will be seen. But the most common long-term complication which will be malnutrition. Okay, due to malnutrition, the patients will be affected. And if ever any vaccine is needed, okay, or any vitamin is needed for the supplement that has to be given is children with the measles and the vitamin A. Okay, this is the prophylaxis that we can give for this patient. That is the important point that you have to remember. Next, moving on to the RDA guidelines. So as per the RDA guidelines, we follow the lifestyles. Okay, and in the RDA guidelines, the generally for the males and the female, how much we are going to give the calories that they have to intake. So sedentary lifestyle, those who have anything, nothing, and those who have mild workout, and those who have the moderate to high level, heavy. So how much calories that has to be given? Just remember the sedentary 2100 kilocalories. You add plus 600 and plus 600. Okay. Next for the females, it is 1600. Okay, or let's say 1660 exactly. Add plus 500 and plus 600. Okay. So this is how we are going to add. Sorry, this is the 700. So you will get the approximate value for this features. Next for the pregnancy, overall will be plus 350 kilocalories, and for the lactation, first 6 months it will be high. Okay, first 6 months it will be high, 600 plus. More than 6 months, it can be decreased to 520 kilocalories. 520 kilocalories can be given for this patient. Next, coming to the protein, in the males, the minimum protein per day is a 54 grams per day, and for the females, it will be just 46 grams per day. And pregnancy women, you have to increase this from the normal level. For example, this is a 46, right? You have to add 10 grams extra per day. Okay, 10 to 20 grams has to be added extra. And for the lactating mother also, for example, 46, right? So plus they have to add the 15 grams per day. This is how they have to be taken, right? Next, another important one. So these are the important points that you have to remember about the weight and also calories and the protein intake for the RDA guidelines. Okay. Next, moving on to the amyloidosis. So amyloidosis is an autoimmune condition, right? Amyloidosis is an autoimmune condition and abnormal protein folding. This is due to abnormal protein. So let's see what are the examples that we are going to see in these patients. Amyloidosis, the patient features will be this kind of tongue. This is the magenta tongue that will be seen, and if there is an inflammation near the eyelids, it can cause nerve damage, also skin damage for the patients, and abnormal bruising will be seen. Okay, all these detrimental effects will be seen due to the amyloidosis. Okay, and it is divided as a two types. One is the primary amyloidosis and second one is a secondary amyloidosis. So primary amyloidosis, the cause is only from the amyloid, and this protein, abnormal protein, is AL. And secondary amyloidosis, this is due to any secondary diseases. Okay, for example, the most common disease is the rheumatoid arthritis. Okay, the most common disease is the rheumatoid arthritis, and here the amyloidosis are AA. Okay, AA, this is the most common one. Okay, this is the most common one. Next, we also have the other things. For example, if it is involves the kidney, it will be involves the dialysis kidney, and these patients will be consisting of the beta microglobin 2. Okay, this is for the kidney, and for the brain, it only having the one beta, that is beta amyloid 1, and this can cause the Alzheimer's development in the patient. Alzheimer's development for the patient. It can cause a cancer, that is a medullary thyroid cancer. So the point is here is the calcitonin, and the type 2 diabetes mellitus. Okay, type 2 diabetes mellitus. It will be islet amyloids. It will be islet amyloid. Okay. Next, Proyon's disease. It will be PR amyloid. And for the heart, heart also it consists. It is a transthyretin, and also familial conditions. Familial conditions, either it could be autosomal dominant or the autosomal recessive. They also contains of the transthyretin. They also contains of the transthyretin. And if ever there is a death, that could be due to heart. Okay, the death will be from the heart patients only. And how you are going to diagnose? The best diagnosis is done by the biopsy. This is the best. Okay, and that can be done by the abdominal fat. Okay, it can be done by the abdominal fat aspiration. From there you can see the histopathological findings, and for the histopathological findings the best stain is Congo red. Okay, Congo red we are going to use, or Lugol's iodine, and even pus positive will be seen here, right? These are the important points about the amyloidosis. Next, moving on to the next picture, identify these conditions. Okay, so first one, these are the acanthocytes. These are the acanthocytes. Acanthocytes is seen in the chronic liver disease. Next, these are the echinocytes. Second picture B, this is the echinocytes. And echinocytes is seen with the chronic renal disease. Chronic renal disease, right? Next one. Here you can see this is a drop, like a drop sign. These are known as a dacrocytes. These are known as a dacrocytes, seen in the myelofibrosis condition. Myelofibrosis condition. And another one is a schizoids. These are known as a schizocytes. Schizocytes. Schizocytes are seen in the HELP syndrome and also DIC patients. This is also seen. This is the schizocytes. Next, this one you can easily identify, right? This is the white cells seen in the G6PD, and these are the sickle cells seen in the sickle cell anemia patients. These are the target cells, right? Seen in the thalassemia patients, and these are the spirocytes. These are the spirocytes, and these are the pencil cells, or we can also call this as a elliptocytes, and these are the macrocytes. Macrocytes is due to B12 or the B9 deficiency. Spirocytes is seen in the hereditary spirocytosis. Elliptocytosis is also hereditary spirocytosis that you are going to see, right? These are the conditions. Another pictures that you can see, these are the ball like, right? These are known as a sideroblastic cells. Sideroblastic cells, also known as a paper hammer bodies. Paper hammer bodies. Next, these are the Howell Jolly bodies. Howell Jolly bodies. Howell Jolly bodies is seen in the sickle cell anemia patients. And next, this is the stippling, which is known as a basophilic stippling. Basophilic stippling. Basophilic stippling is seen with the patients of the lead poisoning. And here you can see these are the hens bodies. Hens bodies, again seen in the G6PD. How can you differentiate between the Howell Jolly bodies and the Hens bodies? Howell Jolly bodies are present in the most, not towards the periphery and the cell membrane, rather than they present individually. But the Hens bodies is present only with the cell membrane. That is how you can differentiate. Next, in the anemia only, we have to differentiate between this iron profile. So, in the iron deficiency anemia patients, iron will be decreased, ferritin will be decreased, and the transferrin levels also decreased. But transferrin binding capacity will be increased. That is a iron deficiency anemia classic. Just opposite to that is a sideroblastic anemia, and here the TIBC is decreased, whereas other values will be increased. And anemia of the chronic disease, you have to differentiate that TIBC will be decreased and the iron will be increased. So this is the only 2 points that you have to remember for this differentiating features. Next, moving on to the AML, leukemias. The frequent questions can be expected in the leukemia patients. So first, the patients who are suffering from the AML, the myeloid and the lymphoid. So the myeloid will be most commonly seen with the adults. Myeloid will be most commonly seen with the adults. And the most common among them is the APL M3 type. And the cytogenetics involved is the 15 and 17. 15 and 17. Next, coming to the AML, AML is having the most common complication is the DIC and the prognosis is worst. Coming to the ALL, this will be presented in the children and they will be having the T12 to T21, that is a good prognosis and involves of the better prognosis if ever there is a T cells involvement. Next, the CML. CML is seen with the middle-aged people and they will be having the mutations with the BCR-ABL gene and they have the massive blast crisis will be seen in this patient. To inhibit this BCR-ABL, the drug is given is the imatinib. And next, coming to the CLL. CLL will be having the Richner classification. This Richner classification is transformation. This is a leukemia and it will be converted as a lymphoid leukemia. And these are known as a DLBCL, which will be converted. And on the lab, you are going to see the smudge cells. Smudge cells will be seen in the CLL. And overall, all the AML or the ALL, CML, CLL, all the types will be, the B type will be the most common subtype. Next, coming to the Hodgkin lymphomas. Hodgkin lymphoma in the India, the most common is the MCHL and worldwide is the NSHL, which will be the most common. And another point that you have to remember, EBV. EBV is involved most commonly in India type and also LRHL and the LPHL. There is no involvement of the Hodgkin lymphoma in these types. Okay, so the NLPHL and also NSHL, there is no involvement of the EBV. And the Ritzenberg cells, popcorn type will be seen in this NLPHL and the NSHL will be the lacunar type. Classical type will be seen in the low lymphocyte rich leukemia types, sorry, lymphoma types. These are the important points and immunochemistry that you have to remember. CD20, CD45 for the overall best prognosis type, that is the NLPHL, and 15 and 30 is for the MCHL for the India type. Next, non-Hodgkin lymphomas. Non-Hodgkin lymphomas, at least you have to remember this chromosomes numbers, translocations, marginal zone which will be at the T11 and 18, mantle zone is for the T11 14 and follicular for the T14 18 and the DLBCL BCL6. Burkitt's lymphoma is the Fmge gene. Burkitt's lymphoma is for the Fmge gene and translocation of 18 and 10, which will be seen 8 and 4. Whichever is 8 coming, that is the Burkitt's lymphoma. Next, epitaxis picture. So you all know that epitaxis, the question can be potentially asked in this epitaxis is how the patient will be having the bleeding. So the most of the bleeding will be seen in the patients with a little's area. Okay, this little's area which will be having, and this is also known as a Kasselbeck plexus. This is known as a Kasselbeck plexus and most commonly is seen with the children, especially when they are no speaking, the patients will be having this condition. What are the arteries that is involved here? What are the arteries that is involved? Remember with the mnemonic of gas. So G for it is a greater palatine. It is a greater palatine. And the A for it is the anterior ethmoidal. This is the anterior ethmoidal. And most important one is the sphenopalatine. This is the most common contributing artery. Next is superior labial. Superior labial artery. Okay, which is not included. Posterior ethmoidal is not included in this patient. And how you are going to treat? How is has to be treated? So first and foremost, how we are going to treat this patient? With the help of the Trotter's method. Okay, Trotter's method. So Trotter's method is nothing but will tell the patient to pinch the nose tightly and elevate the head and and patient should be on the tripod posture, means bending forward. So this is the Trotter method, but it is still not controlled. Then go for the nasal packing. Okay, go for the nasal packing. First start with the anterior, still not controlled, then go for the posterior. Nasal packing should be done. Still not controlled, then we have to go for the ligation of the patient. Ligation should be done. Okay, ligation which will be done with the help of the mnemonic. Remember this as a C. Remember this as a C. Okay, first we are going to block the sphenopalatine ligation. Sphenopalatine ligation will be done and followed by the E. This is the ethmoidal ligation. Ethmoidal ligation. Sorry, this is the ECA ligation. External carotid artery. And followed that there is the anterior ethmoidal. And in between this there is a maxillary. So sphenopalatine artery followed by the maxillary artery followed by the ECA artery. If it is still not controlled, go for the anterior ethmoidal artery. That has to be done for this patient. Okay, this is how we are going to treat the patients who is suffering from this epistaxis. Next, another picture that I wanted to tell here is the CSF rhinorrhea. Okay, CSF rhinorrhea. CSF rhinorrhea patients, the most common cause will be anterior cranial fossa fracture. Okay, especially at the Kirby-form plate. If there is a damage to the Kirby-form plate, the patient will be having this condition. And when the CSF is seen, it is going to form the double ring or target sign, or we also call this as a halo sign. How it is going to look like? Let's see. This is the lightweight color and followed by towards that like this. So this is the CSF and this is the trauma blood. This is the trauma blood. Okay. So this is the picture that you are going to see. I just written with the yellow and red color, but it will be seeing of the pale color only. Okay, it will look like a pale. And the best investigation is the HRCT. And the microchemical test that you can do is the beta transferrin. Biochemical test is the beta transferrin test. And the treatment is assurance. And nothing has to be done for this patient. Assurance. It will go by itself. And if it is not controlled beyond the 2 weeks, okay, rest is important, and not controlled beyond, then you can go for the endoscopy for this patient. Endoscopy can be done for this patient. Okay, next, if you want to treat the septum fracture or if you want to treat the bone fracture, okay, you are going to use the septum for the Ash forceps, and here we will be use the Walsham forceps. Okay, this question can be also potential question. Right, done with the nose. Next, moving on to the breast lesions. So one by one breast lesions, you understand what are the types. Let's see. This is the management, the patient who is suffering from the breast abscess. Common in the lactating mothers, associated with the Staphylococcus aureus, and on the ultrasound you are going to see the collection. Right, collection will be seen in these patients, and the treatment is antibiotics, incision and drainage if there is any severe cases, but the breastfeeding is continued in this patient. Next, this is the breast cancer. Breast cancer, the most common cancer is the invasive ductal cancer that we have. This is the most common type. And where is the location? Upper outer the cortex that you are going to this cancer. And older women, those who are having the increased age, family history, BRCA mutations, radiation, right? All this will be considering as the factors. And triple assessment has to be done: clinical exam, imaging, and the biopsy. Treatment is most commonly surgery, chemotherapy, if ever needed, hormonal therapy, or the targeted therapy that we are going to follow. Next, coming to the benign breast tumor, this is a fibroadenoma. Okay, this is the fibroadenoma. And in the patients who is suffering from the fibroadenoma, it will be well defined hypoechoic mass, and it is also known as a mouse-like mass, and it will be just having the changes with the patient cycle only. And reassurance, if ever there is having any discomfort, then we can go for the excision. Next, last one, this is a very important one. This is the cystic disease. Okay, phyllodes tumor. Phyllodes tumor is a benign condition, and mostly it will be showing the rapid growth. Sometimes it will also damage the surrounding breast tissue, and for that we have to do the wide local excision, and recurrence is more than the fibroadenoma that you are going to see in this patient. Next, TNM staging. TNM staging is very important, right? So TNM staging that you have to remember in this patients, how it is involved. So first, how can you remember? There are the 4 stages: T1, T2, T3 and the T4. Okay, and T2 you just remember 2 to 5 centimeters. So T3 will become more than 5 centimeters, T1 will become the less than 2 centimeters, and the T4 T4 will be involving of the all the valves that the patient will be having. So A, B, C. A will involve the chest wall. Okay. B will be involving of the skin plus the lymphatics, and the C will involve the inflammatory type. This is the inflammatory type. Okay. Next, end stage, N0 no nodes. Okay, no lymph nodes. N1 one node. N2 two nodes. N3 three nodes. Okay, three lymph nodes which will be involving here. Okay, as per this 1, 2, 3 that will be involved in this patients. And the metastasis is most commonly seen with the bones with the help of the Batson's plexus. Okay, Batson's plexus, it is going to cause the bone metastasis. Okay, this is the TNM stadiums that you have to remember, guys. And next, moving on to the thyroid lesions. So the first and foremost important one is the hyperthyroidism. The most common is the Graves disease, right? The most common cause is the Graves disease, and in the Graves disease, it will be involving of the two important one, that is the TSH receptor and also iodine receptor. This both will be damaged in this patient. The drug of the choice for this patient is the methimazole. Drug of the choice for this patient is the methimazole. But if ever the patient is pregnant, so P for pregnancy, P for PTU, that is given for this patient in the first trimester, because methimazole can be detrimental for this patient. And so the lab findings in the primary hyperthyroidism, you are going to see TSH will be decreased, whereas T3 and the T4 will be elevated. Whereas secondary hyperthyroidism, you are going to see that TSH will be elevated, so as the T3 and the T4 will be also elevated. Next, hypothyroidism. Hypothyroidism, the most common is the Hashimoto's. The patients will be suffering from the Hashimoto's, and in the Hashimoto's, it will be involving of the thyroglobulin is the one which will be involved in this patient. And let's see the picture. So the primary, the patient will be having the increased TSH and decreased T3 and T4. Okay, and secondary, which will be show decreased TSH, so as decreased T3 and the T4 you are going to see. Next, thyroid cancers. Thyroid cancers, there are three types. First one is a papillary type. Papillary type is the most common type. Okay, papillary type is the most common, and it will be associated with the radiation. It will be associated with the goiter, and also thyroglossal cyst can be producing this papillary thyroid cancer. Okay, and what is the root? The root will be lymphatic root. Okay, lymphatic spread that will be associated in this patient, papillary thyroid cancer. And somoma bodies, that is an important point side. Somoma bodies is seen here. Next, second one, this is the second most common, that is a follicular cancer. Okay, follicular cancer. And follicular cancer is having the other subtype, that is the Hurthle cell type. Hurthle cell type is seen, and it will be spread by the hematogenous. It will be spread by the hematogenous route. And the treatment here is the hemithyroidectomy. The symbol is hemithyroidectomy is done for this patient. Third one is a medullary type. Third is a medullary thyroid cancer. This is due to amyloid and the involvement of the C cells. C cells will be involved. The calcitonin is positive in this patient. Calcitonin is positive in this patient. And the least type is the anaplastic type, that is a severe type. Next, goiter. Goiter can be associated diffuse. Okay, it is diffuse. Diffuse is seen with the Graves disease. Okay, nodular. Okay, in the nodular, it is considered as a toxic goiter. Nodular is a considered as a toxic goiters. Next, thyroid nodules. Here you can see these are the thyroid nodules, which can be benign also. Okay, benign conditions. Next, thyroiditis, which is due to viral, and it is painful condition. It will be painful conditions. Right, this is the overview of the thyroids. Next, coming to the fractures, different types of the fractures that you have to take note. So first one is the Bennett's and the Rolando. Okay, Bennett's and the Rolando. So Bennett is a type of one most commonly base, okay, that on the olar side, olar base fragment will be damaged. Okay, next, Rolando. Rolando will be on the palmar side, and it will be also involve the first metacarpal. Okay, first metacarpal it will be involved, but it will be involving of the 2 to 3 fragments. 2 to 3 fragments. For example, here only one fragment, but in the Rolando it will be 2 to 3 fragments that you are going to see. Bennett's and the Rolando. This angle, this angle is known as a Bowler's angle. This will be angle at the Bowler's angle at the tarsals fracture. This is for the tarsals fracture. Next, another two pictures. This is the first, this is the second. So first one is seen in the foot. Okay, in the foot, when you see this, this is known as a march or the stress fracture. Involvement of the second metatarso, right? MTP joint will be involved. Second MTP, already seen in the patients of the army persons. Next, second one. This is the boxer's fracture. Okay, it will be involving of the fifth metacarpal joint that will be involved in this patient. Next, this is the love fracture. This is the love fracture, also known as a calcaneal fracture. Calcaneal fracture. Next, here you can see this is the gallows traction. This is the gallows traction. This is a simple skin traction, right? And here also simple skin traction with bandage. Okay, buttocks up with the gallows traction. This is the Thomas splint. This is the Thomas splint. Right, done. These are the important points. Next, what is this one? This is used for the patients of the claw hand, and this is knuckle blender joint, knuckle blender splint. Next, this one is used for the wrist drop. Wrist drop. The one is here cock up splint. This is the cock up splint. Right. Next, this picture is the Milwaukee brace, and here this is the another type. This is the Taylor brace. This is used for the scoliosis, and here it is used for the Pott's spine, those who suffer from the Pott's spine. Another picture, this is the Boston brace, and this is for the aeroplane splint, used for the brachial plexus injury. And again this is the Thomas splint. Okay, Thomas splint. Okay, important points. Next, coming to the Montagia's. Okay, Montagia fracture or the Galeazzi fracture. So first picture is a Montagia fracture. Montagia fracture is involving of the upper 1/3 of the ulna. It will involve the upper 1/3 of the ulna plus proximal ulnar displacement. Proximal ulnar displacement. That is seen with the Montagia fracture. Next, here it will be involving of the middle, okay, or the distal fracture plus involvement of the distal displacement. Okay, distal displacement. This is seen with the Galeazzi fracture. Colles fracture is going to involve the distal radius fracture, same as the Smith fracture. Also it will also involve the distal radius fracture. Okay, but the displacement will be, this will be displaced on the front side. This will be displaced in the dorsal side. Okay, on extensor side. Okay, extensor side, whereas this will be displaced on the palmar side. This will be displaced on the palmar side. You are going to see Smith fracture. These are the two differences that you have to remember, right? Next, moving on to the hip dislocations. Hip dislocations. This is the picture that the patient is suffering from the posterior hip dislocation, and here it is the anterior dislocation. Okay, in the posterior, this is the overall most common dislocation. Okay, overall most common. And remember with the mnemonic of Fadir, how there will be presented, how the patients will be presented. And here you remember like a Fabir. It should be remembered as a Fabir. So let's see. So Fadir means it is a flexion. You are going to see the flexion at hip location, and AD is the adduction of the thigh, and internal rotation and internal rotation, and the limb will be shortened. Limb is going to become shortens. Posterior dislocation. How can you identify the anterior? There will be flexion at hip again and abduction of the thigh plus internal rotation. But here the lung length is increased. Lengthening will be seen in the anterior dislocation. Okay, you can easily identify these points. Next, coming to the hematology drugs. The most common hematology drugs we can give is the iron supplements, right? Iron supplements and the folic acid supplements for all the anemia patients. This can be given, right? If ever there is a increased toxicity with the iron, we can give the defroxamine also, right? This is given for the patients, and also B12 we give. But anemia is not due to the blood disorder, but it is actually due to CKD or the chronic liver disease or any secondary disease. Then you have to give the erythropoietin drugs. Where you have to give the erythropoietin drugs. One of the example is a dabipoietin. You are going to give for this patient, right? Next, if ever the patient is having decreased granulocytes, the patient is having the decreased granulocytes, that means decreased WBC. For this patient, you are going to give the filgrastim. Okay, filgrastim, the drug that we are going to give for this patient. Okay, and antiplatelets. Antiplatelets is given by the aspirin. Okay, aspirin is going to decrease the COX and it will decrease the thromboxane. Thromboxane A2 is also decreased. Next, clopidogrel. Clopidogrel, it is the ADP receptor inhibitor. Right, this is the ADP inhibitor drug. Right, these are the important points. Let's see what are the other. Heparin versus the warfarin. Heparin drugs are parenteral drugs. It is given as a IV and the subcutaneous, and this is going to have the rapid action and it will be monitored by the PTT. It is does not going to cause the placenta and it is safe in the pregnancy. Warfarin is given by the oral liver metabolism and it can cause the defects in the normal clotting factors. So especially it will be inhibiting of the vitamin K. It will be inhibited such as 2, 3, 7, 10. All this will be inhibited by the warfarin. Next, it will be crossing the placenta. It can cause a teratogenicity. How can we decrease? For the heparin, the reversal agent is the protamine sulfate. For the warfarin, it is a vitamin K. And for the dagibatran, it is a idarucumab. And the xanthase inhibitors, XA inhibitors, this will be the adixanate alpha is given for these patients of the reversal agents. Next, radio sensitivity versus the radio resistance. Radio resistance is seen with the G1 phase more than the S phase, and the cell is a platelet, very resistant, nervous tissue is resistant, and also so as the vagina. For the sensitivity is the G2 and M phase, lymphocytes, bone marrow, and the gonads. So there are the two types of the effects. One is the deterministic, other one is the stochastic. So deterministic is a very local and minimal type, and the short time of the duration will be seen. Stochastic is very less risk, but it will be time consuming, like severe carcinogens, severe long term effects like cataracts, that will be coming under the stochastic effects. Okay, so stochastic effects will be the cancer only. So the cancer due to tumor, and here it is going to be the skin lesions, skin irritation, or the hair loss that will be seen. Next, we have the acute radiation syndrome. Acute radiation syndrome has 4 phases. One is the prodromal phase within the 48 hours. The first and foremost common is the nausea and the vomiting. Incubation period, there is no symptoms, whereas onset you are going to see the skin injury, hematopoietic disorders, and also gastrointestinal disorders, nerve and the blood disorders will be seen in this patient. And if it is increased more, and what happens there, you are going to see the convalescent phase, at least the death will be seen in this patient. Okay, this is the acute radiation syndrome. Next, coming to the radioisotopes and their half-life. Technetium 99, it has a 6 hours. Technetium 99 is having the 6 hours if you meet with any other also, and the same technetium 99 is consisting of the if you add the molybdenum for it, it is going to be the 66 hours. Cobalt 57, it consists of the highest, that is the 272 days, and the gallium 67 is for the 78 hours. Indium 1111, it is for the 67 hours. Iodine 123 is for the 13 hours. Krypton 81 is for the 13 seconds only, and the rubidium 82 is for the 65 hours. Strontium is for the 25 days. Thallium is for the 73 hours. Carbon is for the 20 months. Nitrogen is for the 9.5 months. Oxygen is for the 2 months. Fluorine is for the 110 months that you are going to see. Okay, these are the types of the isotypes and their important points that you have to remember. And one more important one that you should not be forget is the FDG, right? For the PET scan we use FDG, and it is consisting of FDG is almost, it will be around 110 minutes. It will be consisting of the 110 minutes. Okay, this is the important one. And some of the nuclear medicine where we are going to use, for example, let's take that iodine 123. Iodine 123 is used for the uh, iodine 131, this is used for the treatment, and iodine 123 is used for the diagnostic purposes. Okay, next one, Cesta maybe. Cesta maybe is used for the parathyroid. This is used for the parathyroid. And also MIBG is used for the pheochromocytoma. This is used for the pheochromocytoma. DMSA is used for the anatomy of the kidney, so scars or anything you can visualize here. Whereas DTPA, again about the kidney, this is for the GFR, okay, glomerular filtration rate, that we can see from here. Okay, these are the important things that can be asked in the examination, you have to remember. Next, competitive non-competitive inhibition. Let's see one by one. First, what is the competitive inhibition? For first, what is a competitive inhibition? For example, here there is a specific receptor and there is a binding site. This is the normal. So what happens in the competitive inhibition? So this cannot be binded. So the main one cannot be binded, but it was replaced by the other one. So other agent will be replaced. This is known as a competitive inhibition. So substrate and the active complex of the enzyme is not properly done with the help of other one, that is known as a competitive inhibition. In the competitive inhibition, there will be increased Km value. Okay, there will be increased Km value and Vmax is unchanged. Vmax is unchanged. Let's see in the graph. Okay, so here there is a maximum Vmax. Okay, this is normal graph, and in the competitive inhibition it is going to be Km is increased, right? So you are going to see this way, sorry, so it will be seen like this. So Vmax is same but the Km is increased, right? This is how the competitive inhibition is seen. And on the lean beaker curve there will be connecting point between these two, Km and the Vmax. That is how you have to identify them. Next, uncompetitive inhibition. Again, this is the substrate active site normally. In the uncompetition, what happens in the uncompetitive inhibitors? So for example, here you can see this is the competition, right? And here the binding is happened, and just beside you are going to have the normal one. This is the abnormal and this is the normal one that you are going to see, right? And here Km will be decreased, so as the Vmax is decreased. So again, this is the normal one and the abnormal one will be decreased, both will be decreased. Okay, next, non-competitive inhibition. Non-competitive inhibition, again let's see, this is a normal and here this is the abnormal. So uncompetitive inhibitions which will be look like this. So here something is binded but this is not at all binding, the normal one is it's a far away place. This is you are going to see. And here the Km will be same but Vmax is decreased. So let's see in the graph. So this is the normal one, right? Km is to be unchanged, so but Vmax is decreased. So this is the presentation of the non-competitive inhibition. And lean beaker curve. So there is a meeting point together, that is a non-competitive. Meeting point in the middle, that is a competitive. There is no meeting at all, that is a uncompetitive. What are the examples? Examples are, here is the poisons, and here the examples are most of the drugs such as statins, and here it is a placental alkaline phosphate. This is placental alkaline phosphate. These are the examples. Okay. Next, hypertension treatment. Hypertension treatment that can be frequently asked question directly. Let's see one by one. As per the new protocol, if ever the patient is having the more than 140 or more than 90 mmHg, okay, and how you are going to treat this patient depends on the age, less than 65 years or more than 65 years. So less than 65 years, the first line of the drug is ACE inhibitors or the herb drugs, or more than 65 years we can give for this patient is a calcium channel blockers. Next, hypertensive urgency. So hypertensive urgency means it is the condition there is no multi-organ dysfunction. So you can give the oral drug, that is a oral clonidine is given for this patient, right? Next, hypertension emergency. Hypertension emergency, there is a multi-drug dysfunction. You have to give the IV drug. IV nicardipine is given. IV nicardipine is given for this patient. Whereas hypertension in pregnancy, so the drug of the choice is IV labetalol is given for this patient. Hypertension patient with the history of the migraine. Okay, next these are the COMAPs. In the COMAPs you can give the propranolol. Hypertension patient with Raynaud's, here you can give the CCBs. Hypertension patient with osteoporosis. For this patient we can give the thiazides because it will maintain the calcium. Next, hypertension patient plus any type of the cancer, or let's say the patient is CKD, diabetes mellitus, all this patient is the ACE inhibitors, even for the heart failure also. ACE inhibitors or the herbs drugs is given for this patient. Okay, these are the proportion that you are going to give for this patient. And if ever the patient is suffering from the hypertension plus anxiety, here also you are going to give the beta blockers for this patient. Beta blockers is given for this patient. And for the patient who is suffering from the hypertension, benign prostatic hyperplasia, here you are going to give the prazosin for this patient. Prazosin is given for this patient. Okay, hypertension and different types of the conditions that we are going to follow this. Next, burns. Okay, burns have the different types. So let's see one by one. So the first degree burn, second degree burn, third degree burn. In the first degree, it is only involves the epidermis. Second degree, it is involves the dermis also. And the third degree, it will be involving of the subcutaneous tissue also. In the epidermis, it is very painful. So the pain will be present. Say so as the second one is also pain will be present in this patient. Whereas third one, it is the painless. Third one is the painless condition that you are going to see in this patient. Okay, that is the one point. Next, coming to the Wallis formula. So rule of 9, you are going to follow the rule of 9. In the rule of 9, you are going to give the adult patients the facial structure, both the front and the back, that will be 9%, and upper trunk, front side is the 18, back side is also 18, and both the arms, upper arms will be 9%, 4.5 front and 4.5 back. And next, both the legs which will be given, first front is the 9, back is the 18, and for the anal region it is 1 only. When it is comes to the child, it will be increasing. For the head itself it is a 18, and for the legs it is a 14 and 14 that we are going to give for this patient. How you are going to calculate? With the help of the Parkland formula. With the help of the Parkland formula, use that it is a 4 ml per kg, 4 ml per kg. See, 4 ml into kgs, and total body surface area which is used for the formula of this patients. So this is the Parkland formula that we are going to give for this patient. This is the burns. Next, you have the abdominal trauma. Whenever the abdominal trauma, our first line of the investigation is the fast or e-fast. Okay, that is how we are going to proceed. And in that for abdominal trauma, the most common blunt trauma. If it is a blunt trauma, it will be involving of the liver. If it is a penetrating trauma, it will involve the spleen. If it is a seat belt injury, it will involve the mesentery. It will involve the mesentery. Let's say the patient is presented. Okay, let's say the patient is presented to our team. First, you saw the blunt trauma, then assess the patient with the fast. Okay, assess the patient with the fast. On the fast, you see no fluid, patient doesn't have no fluid, and patient vitals are stable. Then proceed for the patient with the CACT investigation. Okay, CACT. But if ever you see there is a fluid, the patient is unstable, to control the internal bleeding, you have to do the laparotomy. Laparotomy has to be done for the blunt trauma. Okay, next, penetrating trauma. So, if ever the patient is presented with a penetrating trauma, first again do the fast for this patient, how much damage has been done with that penetrating object, and look after the patient's stability or unstable. And both will be similar only. If the patient is stable, then for this patient, we are going to look after for do not remove the agent. Okay, do not remove the object, whether it is a knife or anything. Same here also. Do not remove. Then stable patient, we can go for OT. Okay, schedule after resuscitation. And for this patient, immediately to control the bleeding, immediately shift to the OT and laparotomy is done for this patient. Here you can see this is a seat belt injury, and this is the penetrating, and this is the blunt trauma. This is the abdominal trauma protocol. Next, we have the different types of the ulcers. So sloping edge will be seen in the healing ulcers. Punched out is seen in the syphilis and the ischemia. Undermined is seen in the tuberculosis. Rolled out is seen in the basal cell carcinoma. Everted is seen in the squamous cell carcinoma. Right, these are the different types of the ulcers and their associations. Okay, next, moving on to the ulcers. This is the image based question that can be expected. First, this is the venous type. Okay, this is the venous type, and here this is the arterial type, and this is the neuropathic type. This is the neuropathic type, and this is the pressure ulcer. Pressure ulcer. And how the venous ulcers will be presented. Venous ulcers will be presented as a exudates like pus formation, and around them there will be granulation is formed. Okay, and it will involve the medial aspects. It will be involving of the medial aspects or the frontal aspects you are going to see. Most commonly seen with the DVT condition, patients with the DVT, and also varicose vein. Right. Next, arterial ulcer. Arterial ulcers are punched out ulcers. These are the punched out ulcers, and it is contains of the necrosis also. Necrosis, which will be seen here, and it will also involve the medial side. Okay, medial side will be involved in this patient. Diabetes mellitus patients. Okay, those who are having the hypertension. Comorbs patients will be having the arterial type. Next, neuropathic. Neuropathic will be painless. First and foremost is it is a painless condition, and it will be also having the deep, it will be consisting of the deep, and it is seen with the diabetes mellitus most commonly. Pressure ulcers, which will be seen with the ulcerations, ulceration formation will be seen, and also it is also deep, but the history will be the patient are immobilized. Immobilization is seen in this patient, that is also seen with the old age. These are the criteria for the different types of the ulcers and their identification. Okay, next, moving on to the rabies. Rabies patient, how the rabies is presented and what is the treatment that you are going to give for this patient. Okay, so first, rabies is going to consider as a three types, three categories. So that is a class 1, class 2, and the class 3. So class 1 patients is just no exposure, just nibbling, touching, that is only touch or the feed, that is seen with the first one. And here the distinguishing feature is intact skin, so no treatment is needed, just wash area. And here there is a exposure with the open skin. So open skin, if you see anything, then you have to give the vaccine. Vaccine is fine for this patient. Next, exposure is again present here, but it is actually exposed with the blood or the mucous membranes. And here you have to give the vaccine and also plus the immunoglobulin is given for this patient. This is what class 3 classification. Next, post exposure, you have the three regimens. One is the Thai, one is the SN regimen. Number of letters you can remember. 4 doses is given for the Thai regimen. On the day 0, day 3, day 7, day 28. SN day 0, 3, 7, 14 and 28 you are going to give. Pre-exposure, whoever veterinary doctors, forest patients, they can take 0, 7, 21 or 28, only 3 doses. And the re-exposure, only 2 doses. If ever is last history more than 3 years ago, then you have to give 0 dose and the third dose that you have to give for this patient. Okay, this is how we are going to give the immunoglobulins for this patient. Next, tetanus types. Tetanus is having the two types. One is a clean wound, other one is a unclean wound. Unclean wound. So first category patients, they are actually took the TT vaccine but less than 5 years. And the category 2, they also took the TT vaccine but it is less than 10 years. Okay, less than 10 years. Third category, TT has been took but it is already more than 10 years. And the fourth category, no history of TT. They doesn't even know that they have took or not. So how you are going to treat the unclean or the clean patients in these categories? So for example, the patient has been taken the TT less than 3 years, just send the patient with the wound care. Wound care has to be done for this patient. Here also wound care is done. Okay, next, for the patients who has took less than 10 years, give the wound care plus TT 1 dose is fine. TT 1 dose is fine for this patient. Again, wound care plus TT plus 1 dose is given for this patient. And more than 10 years, wound care plus TT 1 dose, wound care plus TT plus immunoglobulin is given for this patient. And no history, wound care plus TT more than 2 doses, wound care plus TT all series plus immunoglobulin is given for this patient. So this is how we are going to treat the tetanus. Next, different types of the CNS scores. First one is a Glasgow Coma scale, which can be asked first for the eye. I have the 4, right? E4. And in the E4, no opening, that is a 1. Eyes are open just to the pain, that is 2. Eyes are open to the speech and the verbal, it is 3. Eyes open spontaneously, it is the 4. Okay? Eyes open spontaneously, 4. Verbal responses. No response, 1. And incomprehensible sounds, which is a 2. Inappropriate responses is a 3. Orientation is 5 and confused conversation is 4. And for the motor, it is a M6. No response is the 1 and some normal response, it is a 6. And the purposeful response to the only pain, it is 5. Withdraws to the pain, it is 4. Abnormal flexion, it is 3. Abnormal extension, it is 2. Okay, next, this is the score of ABCD2 score for the patients of the stroke. A is for the more than 60 years, BP more than 140 by 190, and clinical features such as speech impairment is 1, unilateral weakness is a 2, and duration more than 60 minutes is 2, and diabetes mellitus is 1. Next, CHED. This is a CHED score. This is for the AFib who patient is having the risk of stroke. Okay, and how much? C for congestive heart failure, H for hypertension, A2 is a 2 score is given for the more than 75 years, D for diabetes mellitus, S2 is for the previous history or the previous thromboembolism, another 2 points is given, V is for the vascular, A is for the age less than 65, and S is for the sex, especially the female patient. And next, B fast, B for the balance lost, eyes blurred vision, face symmetry, arms involvement, speech deficiency, all this will be seen in this patient. That is for the speech deformity of the CNS course. Next, healthcare infrastructure, how the healthcare has to be maintained in the according to the NHM criteria. So we have the National Health Mission, subdivided as a National Rural Health Mission and National Urban Health Mission. Thanks to Dr. Manmohan Singh, that who has started this health mission in the 2004 to all the citizens of the rural and the urban areas of the patients. And how it is treated? First, this is sub-center, and sub-center followed by the PHC, and PHC will be followed by the CHC, and CHCs which will be followed by the district hospitals, and district hospitals will be followed by the one you are going to see is the colleges, medical colleges. And how the important are this particularly, how they are going to cover the population. In the hilly areas, they are going to cover the 3000 population, whereas in the plain areas they are going to cover the 5000 population. And PHCs, in the hilly areas it will be 20,000 population, and in the plain areas it will be 30,000 population, and in the CHCs, hilly areas it will be 80,000 population, and for the population of the plain areas it is 120 population. Okay, and the district hospitals mostly in the plain areas only, and here the population will be 1,50,000 plus population that we are going to cover. Next, urban mission also we mentioned, right? National Urban Health Mission. In the National Urban Health Mission, urban PHC which will be consisting of the 10,000 population, urban CHC is consisting of the 2,50,000, and urban district hospitals which will be up to 6 lakhs we are going to cover, right? This is the population that they are going to cover. Next, this is the National Health Mission logo, and here Asha worker and Anganwadi worker. Anganwadi worker which will be comes under the ICDS center. They will be comes under the ICDS centers. And Asha workers for the urban population, one Asha workers for the 2000 population, and in the rural they will be for the 1 for 1000 population. Anganwadi workers 1 for 400 or 1 for 800. 800 for the urban population, and the 400 is for the rural or the plain areas population that they are going to cover. And Asha workers most important for the MCH care. Asha workers is important for the drug distributions, also as they can also give the barrier methods, and the OCPs can be given by them. Okay, and they will do the home visits after the delivery or antenatal antenatal care and institutional deliveries. Okay, sanitation program, all this will be done by the Asha worker. And here they will cover the children, pregnant women, and also adolescents and lactating women. All this will be covered in the patients of the children less than 6 years, adolescents less than 19 years. Okay, all this will be covered in the Anganwadi workers. Next, CSF analysis. So for the bacterial, the color will be turbid color, increased in neutrophils. This will be increased of the neutrophils, and increased protein and decreased glucose. Tuberculosis, there will be increased lymphocytes you are going to see, and increased protein, two times increase of the protein that will be seen with the tuberculosis. Viral is most commonly seen with the normal only, but lymphocytes, normal protein, normal glucose with lymphocytes, think about the viral, and high protein, think about the tuberculosis. Okay, next, myasthenia gravis. So in the patients of the myasthenia gravis, remember two differences, Lambert-Eaton syndrome and the myasthenia gravis disorders. Lambert-Eaton syndrome is a presynaptic condition, and the myasthenia gravis is a postsynaptic condition. It is a postsynaptic condition. It has the voltage gated calcium channels abnormality, and here it is problem with the ACH, okay, acetylcholine problem. So the patients who are Lambert-Eaton, they will be active, they will be inactive in the day, and but in the night they will be active because of the calcium release. Whereas myasthenia gravis patient, in the daytime they will be active because of the acetylcholine is present, but in the time of the night they will be inactive by the time the acetylcholine is already gone. Okay, and it is associated with the lung cancer, and it is associated with the thymic cancer. And the drug of the choice for this patient is the pyridostigmine. Okay, and here the drug of the choice is the 3,4-diamino 3,4-diaminopyridine is given for the Lambert-Eaton. Next, myasthenia gravis, the most sensitive test for this patient is the nerve stimulation test that we are going to do, and most specific, and this is considered as a best test, that is the antibodies test has to be done. And the most common antibodies are acetylcholine receptor antibodies, which will be most common, followed by the Musk antibodies is also involved in this patient. This is the antibodies that we present. And another test is a diagnostic test that we perform is the hydrophonium test, and also known as a tensilon test, and ice pack test. Okay, ice pack test, which will be performed as a myasthenia gravis patients. Next, retinal detachment. Retinal detachment have the three types, right? One is a rhegmatogenous, traction, and the exudative. The most common is the rhegmatogenous, and especially those who are suffering from the myopia, these patients will be suffering from the rhegmatogenous. And how you are going to see, the patient will be telling us the symptoms will be the patient is having the curtain falling, sudden curtain falling, that will be seen, and floaters will be seen in this patient. And on the test there will be tobacco smoke appearances, you are going to see, and Marcus gun pupils also present in this patient. Whereas the traction and exudative, traction is seen with the diabetes mellitus, exudative is seen with the any retinal disorders, any retinal diseases, and these are very rare, both are. And here also the symptoms will be curtain fallings, sudden curtain falls, but on the test you are not going to see the tobacco appearances, rather than there will be demarcated lines. And Marcus gun pupils is seen in the tractional and the exudative also. Okay, this is the retinal detachment. Next, moving on to the MTP. According to the new MTP guidelines from the 2022 revised, we can do up to 24 weeks. We can do up to 24 weeks. Okay, 20 weeks is limit for OCP failure. Okay, any OCP failure, only 20 weeks are the limit. If there is any social, for example, rape cases, more than 24 weeks. If there is any rape victims or those who are having the severe diseases, this can cause a severe disease, they can go for the 24 weeks. Okay, but more than 24 weeks, they need the board clearance, and this board is consisting of the OB-GYN specialist and also one radiologist and pediatrician. Okay, and individual RMP from the separate government that you have to have. Okay, this is how we are going to use. Next, for the 20 weeks, less than 20 weeks, one doctor suggestion is fine, opinion. Less than 24 weeks, we need two doctors. We need two doctors' opinion. And who can perform? Any registered medical practitioner, at least he has to have the OBG, or he has done the DGO, or he has have the special training. Okay, he has the special training, at least more than 25, at least more than 25 MTPs he has done or assisted, and then 5 on his or her own they has to perform, and the records has to be maintained at least for the 3 years. Records has to be maintained and has to update every month. And coming to the consent, more than 18 years, female is fine, but less than 18 years, parents or guardians, if ever patient is mentally incapacity also, then also parents and the guardians has to be given, and the DNA samples has to be preserved. DNA samples has to be preserved for this patient. That is how we are going to do. Okay, next, if it is less than, if the patient is less than 9 weeks, then it is a medical. So in the medical, we give the drugs, right? Mifepristone on the day 1, around how much dosage we give? 200 micrograms, plus misoprostol given on the day 3 of 800 micrograms we are going to give. If it is more than 9 weeks, then it is a surgical, and in the surgical, either suction and evacuation or the dilatation and curettage can be done. This is for the MTP. Next, types of abortions. So in the types of abortion, first one is a threatened abortion. Threatened abortion is reversible abortion. So heart rate is normal and os is close in this patient. And how is the treatment? Simply rest and the progesterone. Rest on the progesterone is given for this patient. Next, inevitable abortion. It is irreversible. No matter what you do, the patient will be die. And the heart rate is absent, os is open. Os is open in this patient. And the treatment is suction and evacuation. Incomplete, no heart rate, and the os is open. Os is open. And here also treatment is suction and evacuation. Complete abortion, os will be close, no heart rate. Just treatment is supportive. Control the bleeding, and if ever they having the again clots will be seen, just evacuate them. And missed abortion, no heart rate and close. But on the ultrasound, you have to confirm that the CRL is less than 7 mm. CRL will be less than 7 mm, and mean sac diameter is less than 45 mm. You have to confirm. That is a missed abortion. Again, the treatment for this patient is suction and evacuation for the abortions. Next, ASA grading. So, in the ASA grading, important points, there are the 6 ASA gradings. 1, 2, 3, 4, 5, and the 6th grading. How you are going to give this gradings? First one is the healthy patient. Healthy patient, non-smoker. Okay, healthy patient, non-smokers, no comorbs, no diseases. This is the first category. Second category, the patient is suffering from some condition. Hypertension, diabetes mellitus, or patient is pregnant, or the patient is smoker. All this will be under the second category. Third category, the patient is having the conditions, the diseases is present, but along with the diseases, the patient is also high risk of the complications such as myocardial infarction or the cerebrovascular diseases. So the patient is having the uncontrolled conditions. Complications are seen. Next, fourth one is always that the patient is having the threat to the life. Okay, anytime the patient is having the threat to the life, that is the fourth one. And the fifth one, this patient is surgery is the only choice. Surgery is the only choice. For example, aneurysm rupture. One of the examples is aneurysm rupture, right? Or the patient is having the complete heart block. Pacemaker is the only choice for this patient. This is the surgery only choice. Next, sixth one, the patient is either in the coma or the patient is brain dead. Or the patient is brain dead. This is for the these patients. Next, another important points that you have to remember here is the drugs. So before we move on to the procedure for the any anesthesia, how the drugs is given for this patient. How the drugs is given for this patient. So hypertension drugs, diabetes mellitus drugs. Okay, let's say that the hypertension drugs and sorry, let's discuss diabetes mellitus separate. Hypertension drugs, thyroid medications, steroids, and also seizure medications, psychotic medications. Okay, all these are continued. Despite of the surgery also, you can continue these drugs that can be continued. Next, coming to the diabetes mellitus, you have to stop on day surgery. On the day of the surgery, you have to start the oral hypoglycemic drugs. Oral hypoglycemic drugs has to be stopped on the day. But exception is the SGLT2 stopped 72 hours before. It has to be stopped before 72 hours. Next, oral contraceptive pills. Less than 3 weeks, you have to stop them. Okay, MAO inhibitors. Okay, MAO inhibitors. This is also stopped less than 4 to 3 weeks. You have to stop OCVs and these drugs. Okay, this has to be stopped. And acute tubercular therapy is also stopped immediately. Sorry, it can be also continued. Coming to the warfarin. Warfarin has to be stopped less than 5 days before. Okay, next clopidogrel, clopidrug. This is also 5 days, whereas aspirin has to be stopped on the day surgery if you are giving at the high doses, but in the low doses you can continue. Okay, that is a one point. Next, nothing per oral, or the patient has to be on the fast of the on fasting. The patient has to be maintained for solids. The gap should be at least 6 hours, and for the liquids it is at least 2 hours. Okay, and antibiotics is given 1 hour prior incision. 1 hour prior incision that we have to give. Next, adrenal disorders. So coming to the adrenal disorders, very easy topic and easily identifiable topics that you have to maintain, because no mistake has to be done. So the question can be asked with this image also. Histology. They are the three layers: glomerulosa, fasciculata, reticularis. Glomerulosa will produce the mineralocorticoids, fasciculata will produce the glucocorticoids, and the reticulosa will produce the androgens. And mineralocorticoids such as aldosterone, glucocorticoids like cortisol, and androgens are the dehydroepitestosterone. And medulla, this is the inside the medulla, that will be stress hormones such as epinephrine, and the norepinephrine is produced in this patient. Okay, next we have here the condition is the pheochromocytoma. We have the condition of the pheochromocytoma. In the patients of the pheochromocytoma, there will be increased epinephrine and increased norepinephrine. So the patient will be presented as a hypertension because of this, and also palpitations. So palpitations will be increased for this patient, so as there will be increased timings of the sweat and also headache. These are the complaints. Okay, pheochromocytoma is the most common benign tumor. And in this, there is a rule of 10. 10% of the patient is bilateral condition. 10% of the patient is progressed to the malignancy. Okay. And only 10% of the patients is having the extraordinary symptoms. Extraordinary symptoms will be seen in this patient. And the treatment of the choice patient is A, B, C. So first you are going to give the alpha drugs to control the hypertension, and then followed by the beta blockers. So for example, this is given as a 7 days therapy, and this is given as a 3 days therapy, and followed by there is a C for cure. What is the cure? Surgery. Remove that one. Okay, 3 days before surgery, beta blockers. 7 days before surgery is the alpha blockers. A, B, C. We are going to treat this condition. Okay, investigation of the choice is the metanephrine levels. You have to see the metanephrine levels in the blood that you have to see. Okay, next condition. So another picture that you can see, this is the picture that the patient is having the Cons syndrome. This is a Cons syndrome. Cons syndrome most commonly seen with the adenoma. So those who are having the adrenal adenoma, this is seen with this condition. In the adrenal adenoma, it will increase the aldosterone activity. So if ever increased aldosterone, it can cause the hypertension, one, and it can cause the increased sodium levels, and it will decrease the potassium levels, and it will cause the metabolic alkalosis because of potassium and the H plus ions are excreted from the body. And investigation of the choice is a saline infusion test. Investigation of the choice is a saline infusion test. Okay, and a treatment of the choice is a spironolactone. Spironolactone. These are the features. Next, Addison's disease. Addison's disease means the complete adrenal gland is shattered. So as the cortisol, so as the aldosterone, so as the androgens, all are shattered. There is nothing is working. So cortisol is decreased, so it is going to cause the hypotension. And the cortisol is the hormone for the regulation also. It can cause the hypoglycemia. Okay. Next, aldosterone is decreased, again hypotension is seen, and decreased sodium levels and increased potassium levels, and metabolic acidosis will be seen. Androgens are decreased, so it is going to decrease the libido, but increased pigmentation. Why increased pigmentation? Because all the adrenal hormones is decreased, so ACTH levels will be increased in these patients. So that is why we are going to see the hyperpigmentation. And for this patient, the drug of the choice is the hydrocortisone. Hydrocortisone is given for this patient. And the investigation of the choice is the ACTH stimulation test. ACTH stimulation test that is given for this patient. Okay, and most of the causes are autoimmune conditions only for the patients of the adrenal disease. In India, TB is most common than the HIV. Okay, next cortisol. Cortisol is opposite. The cortisol is highly is present in this patient. Obviously, this is due to exogenous disorders. Thanks to our RMPs who produce this exogenous with the help of the iatrogenic causes. Okay, this is due to cortisol, and these patients will be having the increased features that you can see in this picture. Moon like faces like this one, CNS irritability, thin extremities, there will be bruising, and females will be amenorrhea, hirsutism, and fat will be deposited in the backside, and also gynecomastia, bruises, petechiae, thin skin. This is the presentations of the Cushing syndrome. And Cushing's is associated with the exogenous, right? Cushing's is associated with the exogenous Cushing's syndrome. Then you call this due to secondary causes. But if the Cushing is from the primary, such as disease, this is due to pituitary tumor. This is due to pituitary tumors. Okay, and here investigation of the choice is the ACTH levels. Here also you are going to see the ACTH levels. Treatment is stop and taper the steroids. Stop and taper the steroids for this patient. Next, emergency contraception. So emergency contraception, this pill is contents of the LNG, okay, levonorgestrel. It is contents of the 1.5 mg. 1.5 mg. Let's see one by one. So first, the most common is the LNG only. I pill is the most common emergency pill that is available, and it contains of the 1.5 mg, and only one dose is enough, and it can be took after the 72 hours of the unsafe sexual intercourse. That is fine. Next, you have the UZP method. You have the UZP method. In the UZP method, they use the OCPs, oral contraceptive pills. It could be estrogen and the progesterone, or it could be progesterone only pills also you can use. How you are going to take? On the day one, you are going to take the 2 tablets, okay, followed by after the 12 hours gap, okay, the second dosage, again 2 tabs will be taken. This is how the UZP method is done. Next, another method is Ulipristal, and this is the 30 mg. 1 tab is taken for this patient. 1 tab is taken. Again, this is also 72 hours. This is also 72 hours. Okay. Next, mifepristone. Mifepristone 10 mg to 50 mg. 1 dose is fine. This is less than 5 days. And next, last one is the IUCD, less than 72 hours. Okay, in best case scenario, it is less than 5 days. Less than 5 days. Okay, highly effective. If they ask what is the highly effective, then mark the intrauterine devices. The best is the ulipristal, and least best is LNG. But the most commonly used is the LNG only. Okay, that is the differentiator. Next, cystic fibrosis. So cystic fibrosis is an autosomal recessive condition. This is an autosomal recessive condition, and it will include the CFTR gene. It will be including the CFTR gene. What does the CFTR gene is stand for? It is stands at the location of the chromosome 7. It is present at the chromosome 7. If there is a defect in the CFTR, so the chloride clearance is decreased in the body. Chloride clearance is decreased in the body, and increased sodium. So if this combination is seen, the mucus, okay, plus any fluids in the body will become the thickens. It will become the thickens. So patient will be involved of the multiple organs. Most common is the lungs. Most common is the lungs. So the patient will be having the mucus production, but it is very thick. So if it is a thick, it is prone for the infections. Okay, it is infection for the fibrosis. Okay, this will be seen in this patient. The most common infection is with the help of strep only, followed by the staph, and serious infections by the pseudomonas. Serious infections are by the pseudomonas. Next, it will include the pancreas. So in the pancreas, like A, D, E, K, all these are the fat soluble. So the absorption is decreased in these patients. And endocrine, again pancreas. So in the endocrine pancreas, it will be damaging the alpha and the beta cells. So the patient can have the development of the diabetes mellitus. And the mucus is increased. So infertility is seen in this patient. Infertility is seen because of vas deferens is absent in this patient. Vas deferens is absent. And the test that we can do is the sweat chloride test. Sweat chloride test. At least more than 60 milliequals on the two times. Okay, two occasions it has to be positive. And for the treatment is supportive, and such as other drugs we can use amyloid antibiotics. But thanks to the recent discoveries, we have the drugs such as ivacaftor. Okay, ivacaftor, these are the CFTR modulators. These are the best drugs that we can use for this patient. Okay, next, specific drugs and their side effects. Specific drugs and their side effects. In that, the most important one is the pulmonary fibrosis. Pulmonary fibrosis. In the pulmonary fibrosis, the drugs are associated is the start with the B, busulfan, sorry, busulfan, bleomycin, okay, another one is a bleomycin, and also amiodarone, methotrexate, drug, and also cyclophosphamide. These drugs are associated, and also nitrofurantine. Next, agranulocytosis. Agranulocytosis. Agranulocytosis, all the drugs are C, such as colchicine, clozapine, carbamazepine, and also chloramphenicol. Right? These are the agranulocytosis. Next, gynecomastia. Remember with the disco like digoxin and isoniazid and spironolactone, and C for cimetidine, and also patients with the alcohol, they are more prone, and ketoconazole drugs, gynecomastia. Next, lupus therapy. They're going to cause the SHIP. What are the SHIP? Sulfametazole, sulfa drugs, and hydralazine, right? Isoniazid and prokinamide drugs. All this will be causing of the lupus. And G6PD causes most of all the malarial drugs and also sulfur drugs. Okay, all this will be causing of the G6PD condition. Okay, these are the some important specific drug side effects which will be seen. Next, rate limiting enzymes, most important glycolysis. It is a phosphofructokinase 1. Glycosynthesis, glycogen synthase. Neogenesis, fructose 1,6 bisphosphate. Glycogenolysis is the glycogen phosphorylase. Next, cholesterol synthesis, Hmg CoA reductase. Urine cyclase, it is a CPS1, and pyrimidine synthesis, CPS2. Heme synthesis, which will be ALA synthase, and the ketogenesis, Hmg CoA synthase. Fructose metabolism, aldolase B. Galactose metabolism is the galactose 1 phosphate. Important points of the rate limiting steps. Cytokines. Histamine main action is for the vasodilation and the vascular permeability, and the histamine is released by the mast cells, and mast cells will be stained by the toluidine blue. These two questions is asked. Serotonin is important for the vasoconstriction, vascular permeability. Platelet aggregating factor or the activating factor, it will be improving the platelet aggregation, vasoconstriction, bronchoconstriction, and the permeability. Nitric oxide is a very best drug, endothelial, and it will act by the arginine. It will cause the CGMP activation so that the vasodilation, smooth muscle relaxation will be seen. And another benefit is it will decrease the platelet aggregation. Cytokines. Interleukin 1 is for the fever, 4 and 6 is for the anti-inflammation, 5 is for the eosinophils, 8 for the neutrophils, 10, 13 TGF beta anti-inflammatory. Only TGF beta is for the fibrosis and vascular endothelial growth factor angiogenesis. Interferon alpha acute inflammation. TNF alpha is also for the acute inflammation. Interferon gamma is for the macrophage activation. And coming back to the monoclonal antibodies, the important monoclonal antibodies such as anti-TNF alpha. These are the drugs that will be presented as a infliximab. Okay, infliximab drugs. Next, anti-CD20. Anti-CD20. This is rituximab. Okay, next HER2 and new drugs. This is the trastuzumab. Right, breast cancer patients we use. Next, EGFR. Okay, E and C. This is for the cetuximab. This is for the cetuximab. Next, IL-17. This is for the secukinumab. And VEGF. This is the ranibizumab drug. And IgE is the omalizumab. Okay. Next, eosinophils. If you want to inhibit the eosinophils, this is going to be the duplizumab. And some of the drugs such as RSV. That is the palivizumab. And for the COVID-19, you have the tocilizumab. And Clostridium difficile, it is the benzolizumab. Right, these are the important monoclonal antibodies that is previously asked. And this test is known as a Benedict test. And Benedict test is positive for the glucose, galactose, okay, and also fructose, even vitamin C. It will be positive, but it is negative for the sucrose. This question is asked. Next, coming back to this picture, this is the pressure versus the value of the heart. Frequently asked question. So the volume is decreased. This is the volume is decreased. Where the mitral valve is open, it is going to fill. So this is for the filling. Okay, this is for the filling. And once the filling is happened, it is open the mitral valve. And during the mitral valve, here the S1 is happened and it will increase the pressure. Okay, aortic valve is open. So rapid ejection versus the slow ejection. Right, ejection is done, volume is decreased, and again relaxation is seen. And at this location, S2 is formed. Okay, this pressure volume graph is important. Next, coming to the spirometry, we have the different types of the values. One is the tidal value. Here you can see this is the tidal value. Tidal value is around the 500 ml. Next, residual value. What is the residual value? After all the expiration, the whatever the air is left, that is the residual value. And next, end expiratory reserved value. This will be including only the extra efforts of the expiration. Inspiratory reserve value, extra efforts of the inspiration. And inspiratory capacity, which will include the IRV, tidal value, and the ERV. Vital capacity, which will be including of the 3 IRV, TEV, and the ERV. Okay, total lung capacity, which will involve everything, and the FRC, functional residual capacity, which involves the residual value, ERV, it will be included. Next, this graph. This is the graph of the cystomatogram. Okay, so this is checked for the bladder. And here this is the first early phase where the pressure is decreased. And here in the second phase, the pressure is increased. Sorry, pressure is still constant. Here the pressure is constant, but volume is increased. Once in the third phase, there is a pressure is increased. So here you are going to pee, or here we are going to void the bladder. So this is for the cystomatogram. You are going to check. Next, injuries. So in the injuries, you have to remember this important points such as, for example, this is known as an abrasion. And abrasion is only involves the epithelium. Right, only epithelium or the epidermis it will be involved. And here this is a laceration. Identification for the laceration, you are going to see the irregular, right, irregular borders. It will be more deeper that you are going to see. And this is the incision, right? This is the incision, and here it will be regular and superficial. Next, this is the puncture wound. Remember, this is the puncture wound such as needles, pinpoints, and this is the burns. These are the burns. These are the pressure is a related ulcers, and here these are the tears, and this is the bruise or the contusion. Okay, please refer the full length examples in the forensic medicine. Next, coming to the different types of the shotguns. Okay, different types of the shotgun injuries. So contact shot, usually it will be showing the ragged tear. Close range, it will be very close range that you are going to see here, and beyond the close range, which is more than 1 feet, you are going to see the features like this of the wound. And after that, if there is a nearby shot, these are the two nearby shots you can see. So in the nearby shots, you are going to see the tattooing, right? These are the tattooing that you are going to see. And very distant shot, you are going to see the complete petals are seen. There is no wound that you are going to see clearly like this, but all this will be spreaded like this. So this is the contact close shot, and this is the close range, and these two are the near shots, and this is the distant shot. This is how the wounds will be presented with the shotgun. Next, coming to the biostats. In the biostats, this is the normal, curve, bell-shaped, standard deviation, right? So in this, mean is equal to median, so as is equal to the mode. Okay, so this is the first one, and here you can see this is the second, and here this is the third. Okay, so plus 1 minus 1, this is around 68%, plus 2 is around 95%, plus 3 is equal to 99.9% of the distribution. Next, negatively skewed, positively skewed. So here the mean is unequal than the median, so mode. Okay, mode is higher than the median, median is higher than the mean. Here mean is higher than the median than the mode. Okay, so the tail will be on the right side, that is a positively skewed. The tail on the left side, it is a negatively skewed. Okay, you can remember. And the images that you can recall: bar chart, histogram, scatter plot, line chart, box plot, and the pie chart. Okay, again, line charts, bar charts, histograms, scatter plots, pie charts, surface response charts, pictographs, cubic graphs, and the contour plots. All this will be the different types of the plots. And some of the tests: one is the quantitative test and other one is the qualitative test, right? So quantitative tests are known as a parametric test, and these are the non-parametric tests. If you're comparing the one group, two group, or more than three group, that we are going to see. If you're only one comparing the one group, this is the paired t test, and if you're comparing the more than two, this is the unpaired test, and the more than three is the ANOVA groups. Okay, these questions are asked. And next, qualitative. So first one is the Mech-Niemer test. For the one group, two groups, it is a chi-square. For the three groups, it is a K-Walker test. K-Walker test. Right, these are the tests. Next, coming to the national health programs, identifications of the logos, that is important. This is the Janani Sishu Suraksha Karyakram. This is the Janani Suraksha Yojana. Okay, and here both MCH, mother and the child care, you are going to see. And this is for the deliveries. Only for the delivery care, you are going to see the Janani Suraksha Yojana. And Laksha is for the labor room cleanliness. And this is for the Suman. And here MCH care. And at least mortality and the morbidity has to be 0. Anemia Mukt Bharat logo, we have already discussed 6 into 6 into 6, and this is every 9th month antenatal visit, and here this is a Navajat Sishu Suraksha Karyakram, where you are going to give the newborn care training will be given for this patient. RBSK is contents of the defects identification, diseases identification, any type of the deficiency identification, and any developmental delays. Any developmental delays for this patient. Suraksha clinic is for the STDs. NACO is for the patients of the HIV, and the RKSK is for the 10 to 19 years of the children, adolescents, that is used. And here you can see this is the incentives. 5,000 rupees is for the first child and 6,000 rupees is for the second girl child that you are going to give. Next, logos. This is for the TB. This is for the immunization, leprosy, vector-borne. Nishchay is the one which will be used for the patients of the pregnancy kit. Nikshai is for the TB. This is for the vision logo. ICDS is for the Anganwadi workers. ESI is for the employment, and this is for the non-communicable diseases. Okay, and here you can see this is the picture of the hypertensive individuals. Next, WHO organization, UNICEF, leprosy and iodine supplementation, National Health Mission, vector-borne, vision, women and child development. Dots again is for the TB patients, pulse polio, anemia prophylaxis, World Bank and Ministry of the Health Concerns, and Jan Dhan Yojana ICDS program. Meena is for the child care, whereas Sapna is for the she is for the patients of the leprosy. Okay, this is the globe thermometer. This is a sling thermometer, and this is the kata thermometer. Okay, this is the anemometer, and kata thermometer is for the cooling, and sling thermometer is for the humidity. Globe thermometer is for the heat, and anemometer is for the velocity of the air. Next, another picture, AIDS control program, National Health Insurance Policy, immunization, biohazard waste symbol, collection bags, no smoking is on the 2nd March, no tobacco is on the 31st March, national immunization, cold chain management is for the vaccines, occupational hazards for the pneumoconiosis, leprosy is on the Jan 30th, vitamin A prophylaxis, diaphragm, this is for the vaginal rings, GMPA, these are the Antara, and here you can see these are the IUCDs. Okay, and deworming days, that is asked previously. Deworming days, one is Feb 10th and other one is on the August 10th. Okay, Feb 10th and the August 10th every year. See the difference between the ulcerative colitis and the Crohn's disease. Ulcerative colitis, the patients will be having the persistent diarrhea, abdominal pain and tenesmus urgency, whereas Crohn's disease patients recurrent diarrhea and sometimes abdominal pain which will be seen in this patient. But the bloody diarrhea is most prominent in the ulcerative colitis. Crohn's disease patients is having the diarrhea of the condition. Next, diseases of the local conditions, and it will involve the colon region only, and entire GI from the oral to the ileum, it will be involved of the Crohn's disease. And the histopathological features, it is going to show the crypts, abscesses and the globoid cells, polyps formation will be seen in this patient. Okay, it is a continuous inflammation, but that does not include the submucosa. Submucosa is not involved in this patient. Okay, beyond the submucosa it is not involved. And the drugs that we are going to give is the aminosalicylates, corticosteroids, calcineurin agents and the biologicals. And the Crohn's disease patients, it is a transmural cobblestone appearances and the non-caseating lesions and the skip lesions will be seen in this patient. And here you are going to see the fistula formations also. Same drugs, aminosalicylates, corticosteroids, immunosuppressants and the biologicals is given for this patient. So here you can see we'll discuss the antibodies. The antibodies, there are the different types of the antibodies. For the anti-postsynaptic that we discussed, myasthenia. Presynaptic calcium is the Lambert-Eaton syndrome. And anti-nuclear antibodies is a non-specific type most commonly seen with the SLE. Anti-cardiolipin and the lupus, again this is for the SLE patients. Anti-dsDNA is for the SLE. Anti-histone drug-induced lupus. Next, SSA and the SSP is for the Sjogren's, and along with this is also for the congenital heart blocks. SLE 70, this is for the scleroderma. Anti-synaptase, this is for the myositis and the dermatophysitis. Anti-smooth muscle, that is for the autoimmune hepatitis. Okay, next, anti-desmoglins is for the vulgaris. Anti-hemidesmosins is for the bullous pemphigoid. Okay, next, another important points. Anti-glutamate acetylase decarboxylase is for the type 1 diabetes mellitus. Anti-parietal cells is for the intrinsic factor pernicious anemia. Anti-glomerular basement is for the Goodpasture syndrome. Next, conditions like a Immunodeficiencies. Severe combined immunodeficiency is the most common X-linked recessive condition, and severely this patient is suffered from all the types of the conditions. Okay, T cell receptor is defected here. Ataxia telangiectasia. This is due to defect in the genes of the ATM gene, and here you are going to see ataxia, spiroid angiomas, and IgA deficiency in this patient. Hyper IgM disorder. CD40 cells in the T helper cells are defective for this patient, X-linked recessive, and here there will be associated with the pneumocystis, cryptosporidium, and the CMV infections. Westcott-Aldrich syndrome, VAS gene involvement, and the patient is X-linked recessive, and here they will be having the thrombocytopenia, eczema, and the recurrent infections. Leukocyte adhesion defect, LIST gene involvement, and here there will be late separation of the umbilical cord and dysfunction of the neutrophils. Skin and bacterial infections are common. Cardiac Higashi syndrome. The patient is LIST gene defect. Sorry, this is the LIST gene for the cardiac Higashi, guys, not for the leukocyte adhesion defect. There will be lymph histiocytosis, albinism, and the peripheral neuropathy. And if you see that there is a allergy eczema, that is for the Viscott. But if there is a albinism, that is a cardiac Higashi. Chronic granulomatous disease, it is a NADPH oxidase defect. So there is no defect of the patient with the opsonization or the complement system. So patient is more prone to the catalase positive disorders. Next, moving on to the amniotic fluid in amniotic fluids. So oligohydramnios is less than 5 centimeters and the deepest pocket is less than 2 centimeters. Polyhydramnios is mostly more than 24 centimeters and single pocket is 8 centimeters. Most common causes both for the idiopathy. Amniotic fluid, if it is less due to renal agenesis or the patient is suffering from the hypertension, IUGR, twin babies, ACE inhibitors, post-term babies, all these patients will be having the low amniotic fluid, whereas high amniotic fluid is seen with the GI anomalies, twins, diabetes mellitus, Rh negative pregnancy, and the hypertension. And coming to the amniotic fluid of the green color is seen in the listeria, gold color in the Rh positive, brown color in the intrauterine death, and dark color is in the abruptio placenta, and saffron color is seen in the postterm babies. What is the amniotic embolism? Amniotic embolism is a very rare condition seen after the delivery, idiopathic condition, sudden respiratory distress, sudden collapse of the BP, sudden O2 desaturation, DIC symptoms. Consider this as an amniotic embolism. Treatment is resuscitation and fresh frozen plasma infusion for this patient. Next, physiological changes of the person. So, progesterone is going to maintain the pregnancy, decrease the peripheral vascular resistance, stimulate the smooth muscle relaxation, and prevent the preterms. Estrogen is going to cause the chlasma, cholestasis, and increase the thyroid binding globulin, oxytocin, and the spiroid angiomas. Next, important points such as blood volume is increased, so it will cause the hemodilution. RBC volume, hemoglobin, and the globulins will be increased. And decreased platelets, decreased hematocrit, decreased factor 8 and the 11 will be seen in this patient. Cardiovascular changes S1, S2, S3 will be seen. Early systolic murmur can be heard. Cardiac output and the decreased peripheral vascular resistance is seen in this patients. And some of the important signs. Goodell sign is at the 6 weeks, softening of the cervix. Hagar sign is the softening of the uterine isthmus. So Goodell sign is the cervix, Hagar sign is for the uterine isthmus. So bimanual is for the Hagar, only the one hand that is for the cervix, and it is also around 6 to 10 weeks. Cardiac Higashi or the Jack-Piemer sign, bluish discolorization of the cervix. Osiander sign, pulsation of the vaginal fornix. Palmar sign is the rhythmic uterine contractions. Vesican sign, this is the asymmetrical uterine enlargement that is seen. Next condition, congenital infections. Congenital infections which will be including of the toxoplasmosis, such as it is going to show intracranial calcification, hydrocephalus, chorioretinitis. And the CMV is going to show the periventricular calcifications, glaucoma, and also hearing loss is seen. In the rubella is the most severe one, which will be consisting of the leukomalacia and cataracts, PDA, and the SNHL. Zika virus, microcephaly, atrophy, contractures, and the CNS seizures. Congenital syphilis is going to cause the late hearing loss, Hutchinson teeth, and the rhinorrhea. Congenital heart diseases. Acyanotic conditions such as ASD is the most common. The most common defect is the secunda. Cyanotic is a tetralogy of the phalate, overriding of the aorta, and right ventricular hypertrophy and pulmonary stenosis, and the VST will be seen. And the VST is consisting of the perimembranous, most common pansystolic murmur. PDA is a preterm baby's continuous missionary murmur, and the drug of the choice for this patient is a ibuprofen to decrease the prostaglandins. Abstinence anomaly, lithium exposure is going to cause a box-shaped arrhythmias and also seen in this condition. So shoe-shaped heart, tetralogy of Fallot, box-shaped is abstinence anomaly, and dagger shaped is a partial anomalous, and TGA egg shaped is a TGA, and snowman or the 8 shape is the TAPV, and the coarctation of iota is going to see as a 3 shape. So these are the important points that you have to remember, guys, and all these points are asked in the examination. So please do revise this all the topics which can be asked in the examination, and part 1, part 2, part 3 will be uploaded already, which can be seen in the examination, and all this file will be uploaded in the Google Drive link where you can access for those files and the practice. And guys, do watch the part 1, part 2 and the part 3. So you still have the time, 5 days, and also do the rapid revision of all 19 subjects plus compensate with the Q bank. All these are going to helpful in, because we covered more than 300 topics in this 19 videos, and also part 1, part 2, part 3. So we can expect even in the examination 50 to 80 concepts. Okay, 50 to 80 concepts can be seen in the examination, so please do watch them and also practice them, and don't forget to subscribe and share with your friends, and all the best for the upcoming examination, guys.